The objectives of this module are to first help you to list the guidelines for multidisciplinary pain treatment, and second, to be able to identify factors that influence the rise and fall of multidisciplinary pain treatment. From Descartes through the early 20th century, the specificity theory of pain was highly influential. Specificity theory proposed that pain is, quote, a specific sensation with its own sensory apparatus, independent of touch and other senses. Pain intensity is directly associated with amount of tissue injury, according to this theory. It was in this context that John Bonica, considered by many to be the father of modern pain medicine, began his training in anesthesiology. Bonica observed, while treating World War II soldiers with chronic pain, that surgery and rehabilitation often did not produce pain relief, as would be expected by specificity theory. In search of answers, he began to consult with colleagues in neurology, psychiatry, and related disciplines, and found that these consultations resulted in improved pain outcomes for his patients. He started the first multidisciplinary pain clinic in the 1950s and authored The Management of Pain in 1953. In 1973, he convened a meeting of researchers and clinicians that resulted in the creation of the International Association for the Study of Pain and its journal, Pain. Bonica was the first president of IASP. In 1965, a Canadian psychologist named Ronald Melzack and a British physiologist named Patrick Wall published their article proposing gait control theory. According to this theory, there was a mechanism in the spinal cord that regulated transmission of pain from periphery to the brain. This mechanism could explain why there is no one-to-one correspondence between tissue damage and pain. Gait control theory paved the way for the biopsychosocial model of pain and the identification and study of a variety of biological, psychological, and social factors influencing pain. It was in this context that we observed the rise of multidisciplinary pain treatment. The pain community came together at that time and generated some guidelines for multidisciplinary pain clinics. First, these clinics should have clinicians from various disciplines, including at least 2 physicians, a pain psychologist, a physical therapist, and additional providers as needed to address unique patient populations, for example, an occupational therapist. There should be regular team meetings involving these clinicians. There should also be comprehensive assessment and treatment options to include a physical exam, medication management, biopsychosocial evaluation, cognitive behavioral therapy for pain, which is discussed in another course module, physical therapy, occupational therapy, and an ability to refer outside. And finally, these teams should be co-located and share a common philosophy of pain management. Now, studies suggest that this approach really works. Treatment gains were observed up to 13 years after patients completed treatment, which is impressive. However, they found that treatment gains were only observed if you have all of those pieces of multidisciplinary pain treatment, so no one piece seems to account for the effects. For a good example of the multidisciplinary pain treatment strategy, here is a link to Camper and colleagues' article published in 2015 that provides a review of this literature. Multidisciplinary pain treatments were found to work. They improved patient functioning, they resulted in more patients returning to work, they reduced healthcare costs, they minimized opioid prescriptions, and as a result, clinics spread across the country. So how was this process derailed? First, market forces reduced reimbursement for multidisciplinary pain clinics. In the early 1980s, the American Medical Association's current procedural terminology, or CPT codes, were required for reimbursement. CPT codes placed emphasis on fee-for-service model of healthcare delivery that could not accommodate multidisciplinary clinics' emphasis on packages of services. Clinics had to bill for services separately, and claim denials were common. Managed care took over in the late 1980s and early 90s, and ensured that specific services were not reimbursed unless they were performed at different sites. Second, academic medical centers became more focused on profits and stopped subsidizing multidisciplinary pain clinics. And third, pain fellowship training programs and accreditation bodies increased emphasis on procedure-based care, and produced graduates who went on to work in modality-specific pain clinics rather than multidisciplinary care teams. As multidisciplinary pain clinics were dwindling, the use of opioids to treat chronic pain was rising. The American Pain Society promoted a campaign called Pain, the Fifth Vital Sign, which was later adopted by the Veterans Health Administration and led to greater acceptance of opioids in the treatment of chronic pain. The Joint Commission on the Accreditation of Healthcare Organizations mandated pain assessment and treatment by 2001 in accredited healthcare settings receiving federal dollars. Greater focus on patient satisfaction as a healthcare outcome also influenced this trend, with opioids providing fast pain relief for many patients. Two small retrospective studies that became highly cited suggested that prescribing opioids for pain did not increase risk for opioid use disorders. Together, these factors led to skyrocketing opioid prescription rates and a public health crisis. OxyContin prescriptions rose from 670,000 in 1997 to 6.2 million in 2002. The United States prescribes 50 times more opioids than the rest of the world combined. 27% of patients who are prescribed opioids for short-term postoperative pain or injury-related pain will transition to chronic opioid use. And risk for opioid use disorder increases after just 5 days of use, particularly with long-acting opioids. So do opioids improve pain treatment outcomes? Well, there is some debate on this. According to a CDC systematic review, there is no evidence that opioids improve pain or function beyond 12 weeks. On the other hand, there are many pain management practitioners who argue that some patients do well on chronic opioids. The CDC has released the following guidelines for prescribing opioids for pain. First, nonpharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. Clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh risks to the patient. If opioids are used, they should be combined with non-pharmacologic therapy and non-opioid pharmacologic therapy as appropriate. Second, before starting opioid therapy for chronic pain, clinicians should establish treatment goals with all patients, including realistic goals for pain and function, and should consider how opioid therapy will be discontinued if benefits do not outweigh risks. Clinicians should continue opioid therapy only if there is clinically meaningful improvement in pain and function that outweighs risks to patient safety. For additional resources relevant to the content of this module, please also review modules from this course on pain pathways, pain management, and substance use disorder.